You can't save him. Dr. Michael Bennett's voice cracked across Trauma Bay 3 as the cardiac monitor dissolved into a relentless flat tone. Step back and call the time. A respiratory therapist reached for the ventilator tubing while two residents exchanged defeated glances, but before anyone could disconnect another line, a young ER nurse moved between the bed and the crash cart, caught a fresh pressure bag before it hit the floor, and redirected it onto the patient's floor without asking permission. Wait, she said, her eyes fixed not on the monitor but on the patient's neck. His carotid pulse doesn't match what the monitor is showing. Bennett snapped toward her. Nurse, this is not the time to guess. Stand down. Emily Carter didn't argue. Instead, she pressed two fingers beneath the patient's jaw, looked at the waveform on the arterial line, then reached for the ultrasound probe resting beside the bed. You're wasting precious seconds, one resident protested as he tried to take the probe from her hand. Emily shifted just enough to keep control of it without making a scene, placed it against the patient's upper chest, and studied the screen for less than 3 seconds. The heart's still moving, she said. Weakly, but it's moving. We haven't lost him. Bennett barely glanced at the image. That's artifact. He turned toward the recorder. Prepare to document. Doctor, Emily interrupted, more firmly this time. If I'm wrong, you've lost 15 seconds. If I'm right, he still has a chance. The room fell into an uneasy silence because every pair of eyes now bounced between the respected trauma surgeon and the quiet nurse nobody had noticed until this moment. Bennett exhaled sharply. 15 seconds. That's all. Emily immediately lowered the head of the bed by a few inches, adjusted the patient's shoulder position, and asked for a syringe of saline. A resident frowned. Why does that matter? She didn't answer. She flushed the arterial line herself, watched the waveform sharpen, then looked back at the ultrasound screen. The faint contractions became clearer. He's perfusing, she said. Barely. A nurse beside her whispered, almost in disbelief. She's right. Bennett stepped closer, finally studying the display himself. The movement was subtle, almost invisible, but unmistakably real. The patient's heart had never completely stopped. Resume compressions, Bennett ordered immediately, his voice stripped of its earlier certainty. The room exploded back into motion. Medications were pushed. Ventilator settings were adjusted. Within moments, a weak electrical rhythm returned to the monitor, followed by a fragile pulse that everyone in the room could now feel. Nobody celebrated. The patient remained critically unstable, and Bennett's expression revealed more confusion than relief. He looked directly at Emily. How did you catch that? Before she could answer, another trauma alert echoed through the emergency department speakers. Level 1 incoming. Male, multiple penetrating injuries. ETA 4 minutes. The charge nurse hurried toward Trauma Bay 1 carrying the preliminary EMS report, but she stopped halfway when she noticed a sealed dark gray medical transfer envelope clipped beneath the paperwork. There was no hospital logo, only a small federal shipping label and a single handwritten instruction across the front. Deliver only if Nurse Emily Carter is on duty. Emily saw the envelope for only an instant before someone turned it over, hiding the writing from view. And for the first time that night, the color drained slightly from her face. The charge nurse slipped the gray envelope beneath a stack of admission forms without another word, and within seconds the emergency department was pulled back into motion by the incoming trauma alert. Dr. Michael Bennett turned toward Emily Carter with the same stern expression he had worn all night. You made the right call in there, he admitted, but do not mistake one good observation for authority. Stay in your lane. Emily simply nodded and headed toward Trauma Bay 1 before anyone else reached it. Instead of waiting beside the empty stretcher, she checked the blood warmer, replaced an almost empty suction canister, confirmed that 2 units of O-negative blood were already hanging in the rapid infuser, and quietly moved an ultrasound machine closer to the bedside. A resident watched her rearrange the room and frowned. Emergency medical services, said chest trauma. We probably will not even need that. Emily glanced at the doorway where the ambulance crew would arrive in less than 2 minutes. I hope you are right, she replied. But if they are wrong, we will not have time to set this up later. The resident shrugged and rolled his eyes, convinced she was over-preparing. Moments later, the ambulance doors burst open. A middle-aged construction supervisor was rushed inside after being struck by falling steel beams at a downtown job site. He was awake, speaking clearly, and his blood pressure looked surprisingly stable. One physician remarked that they had caught a lucky break. While the team removed the patient's jacket, Emily noticed something almost everyone else ignored. The man's left boot was covered with fresh concrete dust while the right boot was soaked from a puddle, and the pattern of dirt across his clothing suggested he had twisted sharply before impact rather than being crushed directly. She also saw him unconsciously guarding the left side of his abdomen each time he inhaled, even though he insisted his shoulder hurt the most. "Doctor," Emily said to Bennett, "please order a focused abdominal ultrasound before we send him for shoulder imaging." Bennett barely looked up from the electronic chart. His pressure is holding, and his abdomen is soft. "We are not chasing every possibility tonight." Emily did not argue. She simply documented her concern in the chart, then placed a pressure cuff back on the patient's arm after noticing the first reading had been taken while he was moving. The repeat measurement came back slightly lower than before. One of the residents dismissed it as anxiety, but Emily requested another reading 5 minutes later. This time the number had dropped again. Bennett noticed the trend, but still believed pain was the cause. "Give fluids and reassess," he instructed. Emily complied immediately, yet she continued watching the patient's face instead of the monitor. His answers remained appropriate, but tiny beads of sweat had begun forming along his forehead despite the cool trauma. "Bay." His fingertips also felt noticeably colder than they had on arrival. "Doctor," she said again, "he is compensating. I still think he is bleeding internally." Bennett hesitated for the first time that evening. Before he could respond, the portable ultrasound technician finally entered the room after finishing another case upstairs. Emily stepped aside without another word, allowing the technician to perform the scan. Less than a minute later, the technician's expression changed. "There is free fluid around the spleen," he reported. "Quite a bit of it." The room fell silent. Bennett looked from the monitor to Emily, unable to explain how she had recognized the danger so early. He started to ask another question when the hospital's secure communication system emitted a sharp electronic tone that almost nobody had heard before. A message flashed briefly across the nursing station monitor before disappearing again. Emily caught only 4 words before the screen went black: "Clearance verification pending." The ultrasound findings sent the construction supervisor straight to the operating room. And for the first time that night, nobody questioned why Emily Carter had insisted on looking beyond the obvious injury. Even so, the atmosphere in the emergency department remained divided. One resident quietly admitted she had been right twice, while another insisted she had simply gotten lucky. Dr. Michael Bennett ended the discussion with a sharp reminder. She recognized a pattern. That does not make her the attending physician. Emily accepted the remark without responding and returned to preparing Trauma Bay 3, replacing medication trays, checking airway equipment, and restocking supplies as if nothing unusual had happened. The praise she had unexpectedly earned changed nothing about her routine, yet several nurses now watched her more closely than before, noticing she always checked equipment personally instead of assuming someone else had already done it. Minutes later, another ambulance radio report interrupted the temporary calm. A 58-year-old man was arriving after collapsing during a charity marathon. Dispatch reported severe dehydration, low blood pressure, and possible heat stroke. As the stretcher rolled through the ambulance entrance, Emily studied the patient before anyone connected the monitors. His skin was warm but not excessively flushed, his breathing was shallow rather than rapid, and his right hand repeatedly drifted toward the center of his chest before falling away again. The paramedic handed over the report. He fainted after crossing the finish line. No obvious trauma. One physician immediately ordered aggressive cooling measures. Emily hesitated for only a second before speaking. "Doctor, could we obtain an electrocardiogram first? His presentation does not fully match heat illness." The physician looked at her with visible impatience. "Everyone has chest discomfort after running 26 miles. We are treating what is in front of us." Emily stepped back, helping remove the patient's running shoes while continuing to observe. She noticed a medic alert bracelet tucked beneath the sweatband on his wrist. It listed hypertension, but no history of heart disease. As cooling packs were being positioned, the patient suddenly became more restless instead of improving. Emily looked at the monitor and then at Bennett. "His blood pressure is falling despite the fluids. Please repeat the electrocardiogram now." Bennett paused just long enough to remember the previous patient. "Do it," he instructed. The tracing printed only moments later. The emergency physician studying it frowned before immediately calling cardiology. The patient was showing signs of an evolving heart attack rather than simple heat exhaustion. Treatment changed at once, and the cardiologist later confirmed that the delay could have been disastrous if they had continued treating only dehydration. Nobody applauded, but the room felt different. The residents who had dismissed Emily earlier exchanged uncertain looks. One of them quietly asked another nurse, "How does she keep seeing these things before anyone else?" No one had an answer. Emily herself seemed almost uncomfortable with the attention, choosing instead to wipe down the ultrasound probe and return it to its charger with meticulous care. As she opened the storage cabinet, a small laminated checklist slipped from behind the machine and landed at her feet. She picked it up automatically, then stopped. The paper was old, printed in a format unlike any current hospital protocol. Instead of standard emergency department procedures, it listed a sequence of abbreviated trauma priorities she had clearly seen before. Without thinking, she folded it exactly once and slipped it into her pocket before anyone noticed. Across the room, an older environmental services employee paused while emptying a trash container. His eyes lingered on the way Emily had folded the card, his expression shifting from casual curiosity to quiet recognition. He said nothing, finished replacing the trash bag, and walked away. But before disappearing around the hallway corner, he looked back at Emily one more time, as though he had just remembered something from many years earlier. The older maintenance worker disappeared into the hallway before Emily Carter could ask why he had stared at her so intensely, but the brief exchange lingered in her thoughts only for a moment because another call light illuminated above Trauma Bay 2. She slipped the folded laminated card into the pocket of her scrub top and returned to work as if nothing unusual had happened. Around her, the emergency department settled into the familiar rhythm between ambulance arrivals, yet the atmosphere had shifted. Nurses who had barely noticed her that morning now watched the way she prepared every room with deliberate precision. She never opened supplies she did not need, never reached twice for the same instrument, and somehow anticipated which equipment each physician would request before anyone spoke. Nobody considered it extraordinary by itself, but after two correct clinical judgments in a single shift, every small habit seemed to invite another question. Dr. Michael Bennett found himself studying Emily from across the nursing station more often than he realized. He still believed experience belonged to physicians, not to a recently transferred emergency nurse, yet he could not ignore how often she noticed subtle changes before monitors or laboratory results confirmed them. During a brief lull, he walked past her workstation and noticed the edge of the folded laminated card protruding from her pocket. "That is not one of our emergency department reference cards," he remarked. Emily glanced down, removed it, and looked at it for only a second before answering. It must have been left behind with the portable ultrasound. She placed it face down on the counter instead of opening it again. Bennett nodded and continued toward the trauma desk, but something about her response felt incomplete. She had answered the question without actually explaining why she had folded the card so instinctively or why she seemed to recognize it the instant it touched her hand. Minutes later, the charge nurse approached Emily with a routine request to inventory supplies in one of the older trauma storage rooms. The assignment was ordinary, giving Emily a rare chance to step away from the constant alarms. As she organized airway kits and checked expiration dates, she noticed the laminated card still resting in her pocket. Curiosity finally won. She unfolded it and discovered it was not a hospital checklist at all. Most of the medical terminology was familiar, but the layout was unlike any civilian protocol she had ever seen in emergency nursing manuals. Instead of department headings, each section was organized around time intervals measured in seconds rather than minutes, emphasizing immediate priorities before equipment or laboratory support could arrive. There was no logo, no date, and no institution listed anywhere on the card. Emily stared at it for only a heartbeat before footsteps approached outside the storage room. She slipped the card away just as another nurse entered searching for intravenous tubing. The moment passed without conversation, but when Emily returned to the nursing station, she found Dr. Bennett standing beside the secure communication terminal. The same notification that had flashed earlier had appeared again, lasting only an instant before automatically clearing itself. Bennett frowned at the empty screen. "Strange," he muttered. The system almost never requests clearance verification for nursing staff. He looked around the department without naming anyone, then dismissed the message as a computer error and walked away. Emily lowered her eyes to the patient chart in front of her, saying nothing, but her grip tightened almost imperceptibly around her pen. Across the department, the same maintenance worker from earlier had returned with a floor cleaning cart. As he passed the nursing station, he noticed the corner of the folded laminated card peeking from Emily's pocket once more. He slowed for less than a second, his expression growing noticeably more serious than before, then continued down the hallway without a word, leaving behind only one unsettling question that nobody else in the emergency department yet knew to ask. The overhead speaker interrupted the uneasy silence with another level 1 trauma activation. A delivery driver had been brought in after a high-speed collision, and paramedics reported severe blood loss, with rapidly declining blood pressure despite aggressive treatment in the ambulance. As the patient was transferred onto the trauma bed, Dr. Michael Bennett immediately took command, assigning roles with practiced confidence. Emily Carter moved to the side of the room, assisting without speaking until she noticed the patient's skin becoming increasingly pale while the blood pressure fluctuated unpredictably between readings. The monitor suggested one picture, but the patient's physical signs suggested another. Emily stepped closer and examined the intravenous tubing instead of the monitor. One line had begun flowing far more slowly than expected because the catheter had shifted during transport. She immediately redirected the infusion through the second established line, elevated the functioning limb slightly, and requested that blood products be connected to the rapid infuser instead of relying on the compromised access. One resident objected that there was still measurable flow through the original catheter and insisted replacing priorities would waste time. Emily looked directly at Bennett. If we wait until that line fails completely, we lose valuable minutes. We already have reliable access. Let us use it now. Bennett hesitated only briefly before nodding. Do it. Within moments, the patient's circulation stabilized enough for the trauma team to continue imaging and definitive treatment without interruption. Nobody claimed Emily had saved the patient alone, but everyone in the room understood that recognizing the failing intravenous access before it completely stopped had prevented a dangerous delay. Bennett watched her reset the equipment with the same disciplined efficiency he had seen throughout the night. This time he did not correct her or remind her to stay in her lane. Instead, he quietly asked, "Where did you learn to think several steps ahead like that?" Emily answered without looking up from the tubing she was securing. "You learn to prepare for the problem that has not happened yet." It was an ordinary sentence, yet something about the way she said it left the room strangely silent. Later that evening, while the patient was being transferred upstairs, the older maintenance worker returned with his cleaning cart and stopped outside the open trauma bay. He studied Emily for several seconds before speaking. "Excuse me, Miss Carter." She turned, surprised that he knew her name. The man pointed toward the folded laminated card still tucked inside her scrub pocket. "The way you folded that checklist earlier. I have only seen one other group do that." Emily remained still, but said nothing. The man gave a faint smile that carried more recognition than certainty. "About 15 years ago, I worked maintenance at Walter Reed. Sometimes military medical teams came through for specialized training before deployment. Every one of them folded their trauma reference cards exactly like that before putting them away. Said it kept the critical sequence visible when they opened it again." Several nurses within earshot looked toward Emily without saying a word. The explanation was simple enough to be believable, yet it immediately transformed what had seemed like an unconscious habit into something much harder to dismiss. Bennett heard the last part of the conversation as he stepped back into the department. He looked first at the maintenance worker, then at Emily, then at the folded card. Nobody offered another explanation, and nobody asked another question. Emily quietly excused herself to prepare the next trauma room, leaving everyone else standing with the same unsettling realization. Her instincts, her methods, even the smallest habits no longer looked like those of an ordinary emergency room nurse. As Bennett returned to his office a few minutes later, his desk phone was already ringing. The caller identification displayed only one line: Department of Defense Medical Liaison. He stared at the screen for a long second before answering, unaware that the first question on the other end would not be about one of his patients at all. "I do not want the nursing supervisor," The voice on the other end replied after Dr. Michael Bennett answered the phone. I need to confirm whether Nurse Emily Carter is currently on duty. Bennett glanced through the office window toward the emergency department before answering carefully. She is working tonight. May I ask what this concerns? A brief pause followed. Administrative verification only, the caller said. Please do not interrupt patient care. Someone will contact the hospital if additional information becomes necessary. The line disconnected before Bennett could ask another question. The conversation provided no explanation, yet it left him with the uncomfortable feeling that someone outside the hospital already knew exactly who Emily was. He folded the note containing the caller identification and slipped it into his coat pocket instead of throwing it away. Out in the emergency department, Emily continued caring for patients without any sign that the unexpected phone call had occurred. An elderly woman recovering from pneumonia struggled to catch her breath while waiting for an inpatient bed. Emily noticed the woman's anxiety rising faster than her oxygen level was falling. Rather than immediately increasing medications, she lowered the bed slightly, repositioned a pillow behind the patient's shoulders, coached her through slower breathing, and asked respiratory therapy to reassess the oxygen delivery mask. Within minutes, the woman's breathing eased enough that her oxygen saturation gradually improved. Thank you, the patient whispered, reaching for Emily's hand. You never made me feel like I was just another chart. Emily smiled warmly. Everyone deserves someone who pays attention. One of the newer nurses watched the exchange with surprise. It was not only Emily's clinical judgment that stood out anymore. She never rushed frightened patients, never spoke over families, and somehow made even the busiest trauma night feel a little less overwhelming for the people lying in the beds. The respect around her was growing for reasons that extended beyond medicine alone. As Emily completed her documentation, the same maintenance worker quietly returned to replace a ceiling light outside the trauma base. Passing the nursing station, he noticed a small silver pin clipped inside Emily's scrub pocket. Unlike the laminated card, this object immediately caught his attention because two worn letters had been engraved near the clip. They simply read DP. He frowned for a moment, as though trying to remember where he had seen the marking before, but instead of asking questions he merely nodded politely and continued working. Emily unconsciously turned the pin so the engraving faced inward before placing it back into her pocket. The gesture lasted less than a second, yet Bennett happened to notice it from across the department. The movement reminded him of someone protecting a personal keepsake rather than an ordinary writing instrument. Later that evening, one of the trauma surgeons stopped by the nurse's station after reviewing the earlier construction worker's operative report. Good catch on recognizing the internal bleeding, he said to Emily. The surgeon said another 20 or 30 minutes could have changed everything. Emily accepted the compliment with visible discomfort. The entire team made the difference, she answered. I just saw something that deserved another look. Bennett listened without interrupting. He had expected pride after such a successful night, yet Emily consistently redirected every compliment toward the rest of the staff. That humility made her growing mystery even harder to explain. Just before midnight, the hospital courier arrived carrying a sealed document pouch that required a physician's signature. The label identified the sender only as the Department of Defense Medical Liaison Office. Attached to the outside was a simple instruction printed in bold letters. Deliver directly to Dr. Michael Bennett. Do not open unless Nurse Emily Carter confirms receipt. Dr. Michael Bennett carried the sealed Department of Defense pouch into the consultation room, but did not break the seal immediately. Instead, he walked back into the emergency department and found Emily Carter checking medications before the next patient arrived. Holding up the unopened envelope, he asked, "This package says it cannot be opened unless you confirm receipt. Do you know why?" Emily looked at the label for several seconds before giving a small nod. "Yes, you can open it." Her answer contained neither surprise nor anxiety, only quiet acceptance. Bennett carefully broke the seal while two charge nurses remained nearby to witness the chain of custody. Inside was a single verification letter, a laminated identification card with sensitive details concealed behind a privacy cover, and one official certification page. The first paragraph contained no operational history and no classified information. It simply confirmed that Emily Carter had previously completed an advanced military trauma medicine program authorized by the Department of Defense and remained credentialed to perform battlefield emergency techniques during approved civilian emergency situations when conventional methods were failing. Bennett slowly lowered the page, remembering every unusual decision Emily had made throughout the night. None of them had been guesses. The bleeding long enough to reach the operating suite became the immediate priority. Bennett reacted without hesitation. He turned toward Emily. "Stay with me." Nobody questioned the instruction. Emily moved beside the patient, rapidly assessed the surgical dressing, recognized where external pressure could safely reduce blood loss without interfering with the previous repair, and directed one nurse to prepare additional blood products, while asking another to notify anesthesia that the patient was arriving sooner than expected. Her movements were efficient, coordinated, and completely consistent with the certification Bennett had just read. The transport continued without unnecessary delay, and by the time the operating room doors closed behind the team, the patient's condition had stabilized enough for definitive surgical treatment to continue. Standing outside the operating suite, one of the experienced operating room nurses looked at Emily with genuine respect. That was not something you learned during ordinary nursing orientation. Emily answered with the same humility she had shown all night. "Many people invested time teaching me. I try to honor that by remembering it when someone needs help." The maintenance worker who had recognized her habits earlier happened to pass the hallway at that moment. Seeing the Department of Defense envelope still resting beneath Bennett's arm, he smiled to himself, finally understanding why Emily's smallest routines had seemed so familiar all evening. No grand announcement followed. No one saluted. No one treated Emily like a celebrity. Instead, something quieter happened. Residents who had dismissed her suggestions earlier now asked for her opinion before preparing trauma rooms. Nurses naturally mirrored the organized system she had been using since the beginning of the shift. Bennett himself handed the certification packet back to Emily without opening the covered identification card. "Your past belongs to you," he said. "What matters to me is what I have seen with my own eyes tonight." Emily accepted the envelope with gratitude, slipped it into her locker without displaying the identification inside, and immediately returned to checking on her patients. As she closed the locker door, a worn photograph resting behind the certification packet briefly shifted into view. It showed Emily standing beside several other medical personnel in matching uniforms. But before anyone could see the faces clearly, she gently slid the photograph back into the envelope, leaving one final piece of her story still waiting to be understood. When Emily Carter returned to the emergency department after placing the certification packet in her locker, the pace of the night had not slowed, but something inside the department had undeniably changed. Nobody announced it. Nobody acknowledged it aloud. The newest residents who had once dismissed her observations now prepared trauma rooms using the same sequence they had watched her follow all evening. One nurse quietly repositioned the ultrasound machine before the next ambulance arrived, smiling to herself when she realized she had copied Emily's habit without even thinking about it. Across the room, Dr. Michael Bennett noticed the change but chose not to interrupt it. Instead of assigning Emily routine support duties, he naturally placed her where her judgment would help the entire team most. No explanation was necessary because everyone had already witnessed why. A short time later, the construction supervisor from earlier was transported back through the emergency department after successful surgery on his way to the intensive care unit. Though still weak, he recognized Emily standing beside the hallway and lifted one hand slightly in silent thanks. Emily smiled, adjusted the blanket that had slipped from his shoulder, and reminded him to save his strength for recovery rather than conversation. The gesture lasted only seconds, yet several younger nurses watching nearby understood something they had missed before. The reason Emily earned trust was not because she wanted recognition. It was because every patient received the same steady attention whether anyone was watching or not. During the next admission, one of the residents hesitated while reviewing a complicated medication order. Earlier that evening, he would have ignored Emily completely. This time he looked toward her and simply asked, "Would you mind checking my dosage calculation?" Emily reviewed the numbers carefully, confirmed most of the order, then pointed out one weight conversion that needed correction before the medication reached the patient. The resident quietly updated the chart without embarrassment. "Thank you," he said, and immediately continued caring for the patient. No speeches followed. Respect had become part of the normal workflow. Even Dr. Bennett found his own routine changing. As another ambulance call came over the radio, he automatically turned toward Emily before finalizing the room assignments. "Anything I should prepare that I may be overlooking?" he asked. Emily listened to the dispatch report, considered the mechanism of injury, then suggested bringing an additional portable blood warmer into the bay because outside temperatures had dropped significantly during the evening. Bennett nodded once. "Let us have one ready." The equipment was brought in before the patient arrived, and although it ultimately was not needed, nobody considered the preparation excessive anymore. They had learned that thoughtful preparation was never wasted. Near the end of the shift, the elderly woman recovering from pneumonia asked whether the kind nurse who had helped her breathe earlier was still working. Emily stopped by her room for only a minute, adjusted the woman's blankets, and made sure her call button rested comfortably within reach. The patient squeezed Emily's hand with surprising strength. "You made this place feel less frightening," she said. Emily answered with the same quiet sincerity she had shown from the beginning of the night. "That means you are already healing." As dawn slowly brightened the windows beyond the ambulance entrance, the emergency department finally settled into a rare moment of calm. Emily walked through each trauma bay one last time, replacing supplies, straightening equipment, and leaving every room ready for the next unknown emergency. No cameras followed her. No officials waited outside. The staff simply watched the nurse they had underestimated at the beginning of the shift continue doing exactly what she had always come there to do, taking care of people one patient at a time, while the respect she had earned spoke far louder than anything she ever could. Morning shift arrived just as the first rays of sunlight filtered through the emergency department windows, replacing the flashing ambulance lights that had dominated the night. Emily Carter completed her final patient notes with the same careful attention she had given every task since the beginning of her shift. There was no special farewell waiting for her, no ceremony, and no announcement over the hospital speakers. Instead, she walked through each trauma bay one last time, confirming that medications were stocked, monitors were ready, and emergency carts were sealed for the next team. As she reached the doorway, one of the newest residents quietly repeated the same room preparation sequence Emily had demonstrated throughout the night. Another nurse adjusted the ultrasound machine before the next ambulance arrived without being reminded. None of them discussed why they had changed. They simply knew those small habits gave patients a better chance when seconds mattered most. Dr. Michael Bennett watched the department from the nursing station for several moments before walking toward Emily. In his hand was the laminated trauma reference card she had accidentally discovered earlier in the shift. He had placed it inside a clean plastic sleeve to preserve it after confirming it was not hospital property. Without making a speech, he set it gently beside her travel mug. "You left this behind," he said. Emily looked at the card, then back at him. "Thank you." Bennett nodded once before adding, "The protocol may have come from somewhere else, but what mattered last night was the person who knew when to use it." Emily accepted the card without another word. The conversation ended there because both of them understood that respect no longer required explanation. As staff changed over, the resident who had once challenged nearly every recommendation Emily made stopped beside her workstation carrying a fresh notebook. Before leaving for morning rounds, he carefully wrote a single sentence on the first page. "Prepare for the problem that has not happened yet." He closed the notebook and slipped it into his coat pocket, carrying forward a lesson that had not come from a lecture or a textbook, but from watching someone live it under pressure. Nearby, the charge nurse quietly updated the orientation checklist for future emergency department nurses. Among the equipment reminders and medication checks, she added one simple instruction that had never appeared there before. Verify your assumptions before you verify the monitor. Nobody attached Emily's name to the note, yet everyone on the team understood exactly where the idea had come from. Emily gathered her belongings, placed the folded laminated card beside the silver pen inside her bag, and headed toward the employee exit. As she passed the waiting room, the elderly woman recovering from pneumonia noticed her through the open doorway. She lifted a hand in farewell. Emily smiled, returned the gesture, and continued walking without breaking stride. Outside, the cool morning air replaced the constant sound of monitors and overhead pages. Behind her, another ambulance turned into the hospital entrance, signaling the beginning of a new day and another unknown emergency. Emily paused only long enough to look back at the emergency department where countless lives would continue to cross paths. Then she adjusted the strap on her bag and walked toward the parking lot. Inside the hospital, the trauma bays were already ready before the next patient arrived because one quiet nurse had shown an entire team that preparation, humility, and steady hands could change the outcome long before anyone believed a life could still be saved. And somewhere beyond those automatic doors, the words that had echoed through the emergency department only hours earlier had quietly lost their certainty, because sometimes the forgotten technique is not merely a medical procedure. It is refusing to give up when everyone else already has.